Thank you. Here we are again. This study started from this observation. A patient with bullous keratopathy in both eyes, two DSEKs, the first with a lenticle that was thicker and the second one with a thinner lenticle. You see at the slit lamp both corneas are good, and one cornea is much thicker than the other because of the lenticle, and the visual acuity is the same, as you can see. So I thought maybe it is not the thickness of the lenticle that makes the difference, and this should let us understand the real usefulness of DSEK. It is not really the thickness of the lenticle that is important. There is something else. We know that bullous keratopathy brings about chronic edema due to endothelial failure secondary to trauma or Fuchs dystrophy. And there is edema, stromal edema, epithelial edema with ruptures of microcysts and infections. And we know that this brings about collagen disorganization and anterior stromal keratocyte loss, a reticular network of subepithelial fibroblasts forms, giving rise to irregularities of surface and subepithelial haze. We know that DSEK is the technique of choice together with DMEK for all endothelial diseases. We know that most patients do never get to 20/20, even if at the slit lamp the appearance is pretty good. This can also depend on irregularities of the anterior face of the cornea that are not really understood, or sometimes are underestimated. The purpose of our study is to evaluate the changes in the corneal anterior surface before and after DSEK, and to check whether there are factors that can modify the quality of vision. This is a paper published last month. We selected two groups, a group of patients suffering from bullous keratopathy, pseudophakic eyes, 7 Fuchs dystrophy, and 13 after phaco. Bullous keratopathy was there for more than 15 months, elderly patients, and our control group, same age, but healthy, with no bullous keratopathy. And we analyzed the corneal anterior surface, the aberrometry, and the Zernick polynomials up to the 8th order for 6 millimeters diameter, and 18 of 20 eyes, so 90%, improved their visual acuity. 12 eyes, accounting for 60%, achieved corrected visual acuity over 5 on 10. 6 eyes, 30%, over 8 on 10. So pre-operatively it was 1.1. 1 year later, 0.23. There was a visual recovery, but not that big. Let's go through our results. Low order aberrations in control and in pre-op DSEK groups were very different. Patients with bullous keratopathy have more astigmatism. Also low order aberrations are more than in control groups. Look at high order aberrations before surgery. Patients with no bullous keratopathy have these high order aberrations. Those with bullous keratopathy have much higher values. They start with more irregular cornea, and after surgery, low order aberrations, astigmatism, are reduced but do not modify significantly. Astigmatism before and after stays the same in patients with bullous keratopathy. And also high-order aberrations do not change significantly from 3.28 to 2.8 year later. There is a reduction, but not significant. These eyes become transparent, but corneal aberrations do not improve. With high corneal aberrations, you can't see very well. And this is the total high order, and these are the subgroups. You see pre-op and then post-op. It doesn't change that much. I mean, it is not statistically significant. There is no significant variation in terms of aberration before and after surgery. We wanted to see whether there was a correlation between aberrations and decrease in visual acuity. And there is a significant correlation, and you see that the relationship between eye order and age, there is no significant correlation. And this is a patient. Before surgery, he would see 2 on 10, and this was high order aberration level. And 1 year later, visual acuity has improved, the aberrations have stayed the same. This is a transparent cornea, but I can't see more than that 7 on 10. So this is the point. In patients with bullous keratopathy, some corneal abnormalities persist after DSEK. Corneal anterior eye order aberrations are higher in patients with bullous keratopathy than in control subjects, and stay higher through 1 year, through 12 months after surgery. So post-op CDVI correlates with irregularities of the corneal anterior surface. Corneal transparency is not enough. It's important to assess aberrations to judge refractive and visual acuity values after surgery. Thank you very much.